How do we make the diagnosis? And what other disorders should be considered in patients with certain symptoms that are utilized to make the diagnosis of Parkinson's disease? So the clinical diagnostic criteria for Parkinson's disease are based on the presence of these primary features. It is important to recognize that despite the advances in certain diagnostics, including radiological diagnostics, the diagnosis of Parkinson's disease is still made based on history and examination. And the examination is part of the broader general physical exam, but specifically the neurological exam and the finding of these three cardinal features. The most classic feature is that of a tremor predominant when a part of the body that it is involved is at rest. And this may involve the wrist, the fingers, the elbow, the shoulder, the joint. A tremor is a sinusoidal movement around an axis. It's a to and fro, regular rhythmical movement. And the tremor of Parkinson's disease is predominantly present when the affected part of the body is resting. The tremor dampens when that part of the body initiates movement, and then when a sustained posture occurs in that part of the body, the rest tremor may then come back out. The second cardinal feature, diagnostic feature, is rigidity. Now, rigidity is a finding on examination. So this is something the physician or nurse practitioner or nurse will feel on the exam. This is an involuntary velocity-independent resistance to passive movement of a joint. So if you move the elbow to and fro, you'll feel a resistance to that passive movement. And it isn't dependent on how fast you stretch the movement. That's why it's velocity independent. The increased tone that we feel after a stroke, which is spasticity, is velocity dependent. Rigidity is velocity independent. You feel the same resistance despite any change in the velocity of the stretch of that muscle. The third cardinal feature is akinesia, absence of movement, or bradykinesia, slowness of movement. And the slowness of movement can affect any skeletal muscle. So slowness of movement in the facial muscles, decreased eye blink as a result, decreased facial expression, bradykinesia of the pharynx and mouth, so decreased speech volume and clarity. There can be slowness of movement of the limbs, so trouble with handwriting, with the handwriting being small and scribbly, trouble buttoning buttons, trouble dressing. Bradykinesia of the lower extremities, trouble getting out of deep chairs into the car, slowed walking. All of those are examples of bradykinesia, or the third cardinal feature. So in order to have a diagnosis, we need two of these three, as long as one is either bradykinesia or rest tremor. So a patient with bradykinesia and rigidity would qualify. A patient with rest tremor and bradykinesia would qualify. So two of these three cardinal features. Now, some of you may recognize this mnemonic trap, which includes the three features we've already gone over, but a fourth feature, which is postural instability or impaired balance, is a later classical feature in Parkinson's disease, but often this mnemonic is utilized for the diagnosis. But we need two of these four, as long as one is either rest tremor or bradykinesia. So a patient with rigidity and postural instability wouldn't fulfill the criteria diagnostic for a diagnosis of Parkinson's disease. All right, so we've talked a little bit about this already. The rest tremor, rhythmical sinusoidal movement around an axis, predominantly present when that part of the body is at rest, dampens with initiation of action, may reemerge with sustained posture. You need to evaluate the whole patient, looking at the face, looking at the arms, looking at the legs. And a patient may also describe an internal tremor that may not be visible. Typically, the tremor is asymmetrical at onset, so affecting one side first, and then one side more predominantly than the other side. We've talked about bradykinesia, again, usually starts asymmetrically. Patients will complain of trouble with certain tasks, buttoning buttons, trouble brushing teeth, trouble arising out of deep chairs in the car. Small handwriting can be an early feature. Patients will notice that the handwriting has become small and scribbly and becomes worse as they try to write for longer periods of time. On exam, we'll see this slowness affecting any of those skeletal muscles. Also, we'll notice difficulty doing repetitive movements, and we'll see that in some videos to come. Many patients describe the slowness as weakness. It's not really weakness, because when you directly examine muscle strength is normal. It is a slowness of movement, the trouble doing those movements that we've discussed, that is actually what patients may describe. Diagnosis of Parkinson's disease, the findings of those cardinal motor features are required to make the diagnosis. But oftentimes, these same symptoms and signs are present but are misdiagnosed and are part of this prodromal prior to the Parkinson's disease. Patients may be misdiagnosed as having problems with arthritis, or their speech is impaired because of reflux or other symptoms. So these symptoms are present, but they are insufficient to make the diagnosis, or perhaps were misdiagnosed for other potential medical problems. Preceding this prodromal phase, before any of these cardinal features are present, oftentimes there is a preclinical phase. And in this phase, patients may demonstrate other symptoms that are not yet the classic motor symptoms required for diagnosis. This may include loss of smell and taste. They may complain of vivid dreams, acting out their dreams, REM behavioral disorder. There may be anxiety and depression, other sleep problems that are preclinical signs prior to the diagnosis of Parkinson's disease. And this graph demonstrates the progression of those prodromal symptoms that patients may experience in retrospect when the diagnosis is made. And we ask about these. Oh, yes, these were present before the motor symptoms occurred. But it's important to recognize that patients who may have some of these prodromal symptoms to specifically evaluate whether bradykinesia, tremor at rest, or rigidity are present, because then the diagnosis is able to be made. Okay, so we talked about the prodromal period, looking for these other non-motor symptoms, obviously obtaining family history for neurological disorders, including Parkinson's disease, would be important for the small percentage of cases which are associated with a specific genetic abnormality. In the diagnostic period, it's important to do the physical exam. It needs to include bradykinesia as well as either rigidity or tremor. So we need bradykinesia, either rigidity or tremor, to go along with bradykinesia for the clinical diagnosis. There may be other signs of bradykinesia as part of the exam that we've gone over already. And these then are consistent with a diagnosis of Parkinson's disease.